When you hear the word cholesterol, you may immediately think of something dangerous that needs to be lowered as much as possible. But cholesterol is not simply good or bad. Your body actually needs cholesterol to survive. It is used to build cell membranes, produce certain hormones, and help make substances that are important for digestion. The real question is not whether you have cholesterol, but whether your cholesterol levels and overall health are creating a higher risk for heart disease and stroke. This is where cholesterol numbers can become confusing. You may receive a blood test showing total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides, and you may be told that one number is high or another is low. But a single number rarely tells the entire story. Two people can have the same LDL cholesterol level, but have very different cardiovascular risks because of their age, blood pressure, smoking status, blood sugar, family history, kidney health, lifestyle, and other factors. Total cholesterol is one of the most commonly discussed numbers. In general, a total cholesterol level below 200 milligrams per deciliter is considered desirable for adults. A level from 200 to 239 is generally considered borderline high, while 240 or higher is considered high. But these categories should not be interpreted as a simple diagnosis of heart health. Total cholesterol is made up of different types of cholesterol and other blood fats, so knowing the total number alone can sometimes be misleading. LDL cholesterol is often called bad cholesterol because high levels can contribute to the buildup of plaque inside arteries. LDL particles can enter the artery wall, where they may contribute to a process that eventually produces atherosclerosis. Over time, this buildup can narrow arteries or make them more vulnerable to developing a clot. That is why LDL is an important part of assessing cardiovascular risk. But there is something many people misunderstand about LDL. There is no single LDL number that means exactly the same thing for everyone. For someone who has already had a heart attack, stroke, or certain other cardiovascular conditions, doctors may recommend a much lower LDL target than they would for someone without those conditions. People with diabetes, chronic kidney disease, or a strong history of cardiovascular disease may also have different treatment goals. This means that asking, "Is my LDL normal?" is useful, but another question may be even more important. What LDL level is appropriate for my personal risk? HDL cholesterol is commonly known as good cholesterol. HDL helps transport cholesterol away from certain tissues and toward the liver, where it can be processed and removed from the body. In general, higher HDL has traditionally been associated with lower cardiovascular risk. However, HDL is not a simple protective shield. Having a high HDL number does not automatically cancel out the risks associated with high LDL, high blood pressure, smoking, diabetes, or other factors. This is one reason cholesterol should never be viewed as a competition between good and bad numbers. A person may have a high HDL level and still have significant cardiovascular risk. Another person may have a lower HDL level, but have a favorable overall risk profile. Your doctor needs to look at the complete picture rather than focusing on one number. Triglycerides are another important part of a standard lipid panel. They are a type of fat found in the blood. Your body can produce triglycerides, and they can also rise after eating certain foods, particularly when overall calorie intake is high. Persistently elevated triglycerides can be associated with metabolic problems and increased cardiovascular risk, especially when combined with other unfavorable lipid patterns. A triglyceride level below 150 milligrams per deciliter is generally considered normal. Levels from 150 to 199 are considered borderline high, while 200 to 499 are considered high, and 500 or higher is considered very high. Very high triglycerides can require medical attention because they can increase the risk of acute pancreatitis, a serious inflammation of the pancreas. Another important point is that cholesterol levels are not permanent. Your numbers can change over time because of diet, body weight, physical activity, genetics, medications, alcohol intake, certain medical conditions, and changes in metabolism. A cholesterol test is therefore more like a snapshot than a permanent label. You might have a cholesterol level that looks normal today, and see it change several years later. That does not necessarily mean you did something wrong. Aging, changes in activity, changes in body composition, menopause, thyroid problems, diabetes, kidney disease, and certain medications can all influence cholesterol and triglycerides. Genetics can also have a major influence. Some people naturally produce more LDL cholesterol than others, even when they eat a relatively balanced diet and maintain a healthy weight. Familial hypercholesterolemia is one example of an inherited condition that can cause very high LDL cholesterol from an early age. People with this condition may have a substantially increased risk of cardiovascular disease and may need treatment beyond lifestyle changes. This is why saying, "My cholesterol is high because I ate too much fried food," is sometimes an oversimplification. Diet matters, but genetics and overall health can be equally important for some people. Another misconception is that cholesterol only matters when you have symptoms. High cholesterol itself usually does not cause obvious symptoms. You can feel completely healthy while cholesterol-related plaque is gradually developing inside your arteries. This is why blood testing and cardiovascular risk assessment can be important even when you feel perfectly fine. At the same time, discovering a high cholesterol number does not mean that a heart attack is about to happen. Cardiovascular disease develops through multiple interacting factors, often over many years. Cholesterol is one piece of the puzzle, not the entire puzzle. Blood pressure is another major part of that puzzle. Persistently high blood pressure places additional stress on artery walls and can increase cardiovascular risk. Blood sugar also matters because diabetes and insulin resistance can significantly affect cardiovascular health. Smoking, physical inactivity, excess body weight, sleep problems, kidney disease, and family history can also influence overall risk. This is why two people with identical cholesterol numbers may receive completely different medical advice. Your doctor may also look beyond the standard lipid panel when the situation is unclear. Tests such as non-HDL cholesterol, apolipoprotein B, or lipoprotein A can provide additional information in certain people. These tests are not necessary for everyone, but they can sometimes help clarify risk, particularly when there is a strong family history of early cardiovascular disease or when standard cholesterol numbers do not tell the full story. Lipoprotein A, often called LPA, is particularly interesting because it is largely determined by genetics and is not routinely included in every standard cholesterol test. Elevated LPA can increase cardiovascular risk even when traditional cholesterol numbers appear acceptable. Because levels are strongly influenced by genetics, some people may benefit from having this measurement checked at least once, especially if they have a family history of premature cardiovascular disease. There is also an important difference between normal and optimal. A laboratory reference range is not necessarily the same thing as the ideal level for preventing cardiovascular disease in a particular person. A result can fall within a broad laboratory range while still being higher than what might be appropriate for someone with significant cardiovascular risk.